Thanks so much. I was thinking of the total tuition dollars that you just outlined in all of our CVs. It was a little striking. I should say that Andrea Tentner is in the room with me here, and will take over for me for a couple of slides, and so I'll jump in. I should say this is a team effort, and I'm representing us. I like to tell people that if you're the smartest person in the room, you're in the wrong room, and fortunately, at the University of Chicago, people will always tell you that that's not a risk as long as they are in the room. But I should say that Andrew's kind of been the lead data scientist on this. Amy Spellman has been the chief logistician. We have a number of folks that have been active. We have Nuha Jessica Smith-Atassi and Roberta Livingston have been involved in the outreach work that I'll get to later. And Ruth Kaufman and Rosanna Ander are key managers in our urban labs. Tony Sadler and Allison Stinson have done important qualitative work on this, and Cameron Day assisted with the data science. And my two colleagues, David Meltzer and Robert Gibbons, are distinguished health services researchers involved in this effort as well. So this is a big team effort. So we have an action-packed roadmap, and I'll start. I'll give you a couple of vignettes that give you the nature of the challenge. And then I'll talk about how we try to identify people at the risk of, for want of a better term, I'll call behavioral crisis, which really describes a diverse set of interactions where someone might not respond in a way that's expected or desired by police or ambulance first responders. I'll talk some about what the very mundane realities that help us, that turn out to be really important for understanding a good emergency response from a bad one. And then talk about some of the strategies based on person, place, or events that we could use to improve that emergency response. And then I'll get into the opportunities and challenges in the predictive analytics. And I'll end the talk right around 5 o'clock tonight with a discussion of a pilot intervention that we've done and some of the preliminary findings that we have from it. So I hope that's an okay strategic doctrine for the next 40 minutes or so. So around the country, police departments are facing enormous criticism, basically that have occurred because of tragedies that involve individuals who are in behavioral crisis. Someone calls 911, and then something truly horrible happens. And here in Chicago, the Laquan McDonald videotape is the most famous example, but there are others as well. These crises can be the result of severe mental illness or serious mental illness. They can also be the result of other things, ranging from acute intoxication, developmental disabilities, or many other causes that lead someone to behave in an unexpected way or to be non-compliant with police or others. And in the policy world, we're trying to do a better job to deal with these issues. We have some new tools, for example, through Medicaid expansion that allow us to give new services to people, but we don't know how to use those services very well at all yet. And so that's what we're working on many of these fronts right now. So just here in Chicago, the most famous example, as I mentioned, was the Laquan McDonald shooting. Laquan McDonald is a young man who had a series of personal challenges and who experienced a behavioral crisis that involved people calling the police. The police were actually following him at a distance, and he is sort of cornered on a street in Chicago when surrounded by police, and then one officer, Officer Van Dyke, drives up and pumps Laquan McDonald full of bullets, and Laquan McDonald dies. Shot, I think, 16 times. And the police, by the way, there's two striking things about the other officers involved in that incident. If the whole thing was on videotape, if you watch that videotape, everything up until the point where Officer Van Dyke drives up and kills the kid could be a training film for how to do it right. These officers are using time and distance principles. The key de-escalation principle when you're dealing with someone in a crisis is give them the time to calm down and keep them away from yourself or the people where there might be violence. Everyone's doing a great job, but then they all lie about what happens. Or I shouldn't say they all do, but many of them lie about what actually happened in the incident when Officer Van Dyke drove up and committed an unjust unjustified homicide for which he was later convicted. Another case involved a young man named Quintonio LeGrier. He and the bystander Betty Jones were shot in a similar confrontation that involved a mental health crisis. So here in Chicago, we've had quite a challenge. But I'm going to start out with a different kind of challenge. This is a young man named Robert Saylor. Robert Saylor is a 26-year-old man in Maryland, and he lived with Down syndrome, and he went to the movies one night. And he went. He had a young woman who was there with him, who was his sort of attendant. And they go to the movies, and the movie ends, and they walk out into the lobby of the movie theater, and Mr. Saylor starts getting very agitated, and he and the young woman calls Mr. Saylor's mom and says, what should I do? He's getting pretty agitated. So Mrs. Saylor says, you know what? Why don't you go out, get the car, drive it around. Maybe he'll calm down a little bit. And she gets in her car to come down to the theater to try to help out. And so while his attendant goes off to get the car, Mr. Saylor goes back into the theater. And he sits down at his original seat. He was getting very agitated because he wanted to watch a movie again. And you're not allowed to do that. So the manager comes over and he starts getting into it with Mr. Saylor. And the caretaker comes back and she sort of encounters this situation. And she's 18 or 19 years old. And she says to the manager, don't touch him. Let's calm him down. Whatever. He's not going to respond well if you sort of get in his face. And the manager looks at this young woman, and he's sort of thinking like this 18-year-old young woman's going to tell me how to do my job. He ignores her, and he calls the mall security. And the mall security turned out to be 3 off-duty sheriff deputies, in that Maryland County. And again, the attendant says, please don't touch him. That's just going to rile him up more. And they, of course, look at her and say, this 18-year-old girl's going to tell me how to do my job as a police officer. And they start struggling with Mr. Saylor. And so around the time that Saylor's mom shows up at the movie theater to help, she walks in on the scene where these 3 deputies are on top of Mr. Saylor, and he has actually just died. They pushed him. He was restrained prone, and he asphyxiated, in the struggle. And the officers are actually charged with homicide, but they are acquitted. And one of the things that they say, the judge is very scathing. He says this young man was died over a $12 ticket. But one of the things that the officers say quite correctly is that they had actually followed their training, and that they kept escalating. Their training was to keep escalating until a person complies with what you're asking them to do. And they kept doing that, and Mr. Saylor never complied. Now, you might say that's an unusual situation, but here's another story. This is Dr. David Dow. Anybody remember this story? So he was on a United flight in our beautiful O'Hare Airport. And he's a doctor who had been basically overbooked on a flight, and he refused to get off. And, of course, we being upper middle class, pampered academics, I can't tell you how many emails and tweets that I got about how this is such an example of United's horrible service. But he basically refused to leave, and the police ended up dragging him off, and he was badly hurt. Totally different situation, totally different reason for the confrontation. But what was similar is here's a man in a chair who's not harming anyone, who is badly injured because police are trying to extract him from a chair. And that's actually a very difficult thing to do without having somebody get hurt. And 2 totally different situations that involve the need for de-escalation as a core skill. So you can get a sense there's a whole range of problems that are important, and that police are often very poorly prepared to deal with. Okay? So what are the opportunities for intervention in this type of a situation? We like to think in our work that there are 3 different categories of interventions that can be done. One is we call person-based interventions. So there's a person who has a predictable risk. Laquan McDonald was not a randomly drawn person from the population. He had some prior risks that we knew, might be dealt with in a better way. So proactive interventions, assertive community treatment, forensic assertive community treatment are examples. We have ways of helping identifiable individuals before a behavioral crisis occurs. There's also event-based interventions. When a 911 call is made, can we identify that it's going to involve this type of a behavioral crisis, and then dispatch officers, if it's a police case, dispatch officers to those calls who are well-trained to deal with that. And here in Chicago, there's a 40-hour training in de-escalation and related principles. And as I mentioned, time and distance principles are really the two critical things. If you think about Mr. Saylor, if they had a little bit more time, his mom would have shown up and she just would have bought him another movie ticket, and this whole thing would have been over. But with time, you get someone else who can help. You have other people who might show up with who have different skills or who have more equipment. If you do have to restrain someone, you can have 10 people show up with the right equipment, so it's less likely to be dangerous to everybody. And there's also particular training that people might have. For example, people with developmental disabilities, you never want to restrain them prone because they have certain morphological challenges that make it more likely that they will asphyxiate. So you always want to be able to see the person's face and have their face turned to the side so you can make sure that they're breathing. There's a series of event-based interventions that you could do. And there's also place-based interventions. So, here in Chicago, we have many cases like that happen at O'Hare Airport, that happen at the bus station, that happen in places that have a staff where you could actually coordinate addiction treatment facilities, where you could actually coordinate ahead of time what to do. Now, if you have a loved one with a particular disability who's living in your private home, you might not have a staff, but there are ways that you can enter data into something called the Smart 911 system so that people might know, for example, suppose your loved one is deaf. You could include that information so that a first responder would know this person is not going to respond to my commands because he can't hear those. And of course, these three categories might overlap. And so we're working on different types of interventions that are based on person, event, or place. So one thing that we found, what I'll do is I'll first talk about some of the qualitative research that largely Tony Sadler did, and then we'll get into the predictive analytics that Andrea was the lead researcher on. We found that mundane realities of police work make an incredible difference, and I'm sure this is true in Philadelphia and it's true in Chicago. So one issue is, suppose that you're in a relatively low crime part of the north side of Chicago, and it's 2:00 in the afternoon, and there's a guy standing in the street, and he's carrying on a loud conversation with Jesus, and Jesus is talking to him too, and the police come on the scene. They're actually pretty good at dealing with those types of situations for a whole variety of reasons. Officers that is something that they really are likely to bring their A game to. Assuming that they've been properly trained. But let's have a different situation. I was on something called the Police Accountability Task Force after the Laquan McDonald killing, the de-escalation working group. And we heard from officers what it was like out there. And one of the things that we heard was they had a big challenge with an incident that's similar to but slightly different from the one I just described to you. So the policewoman was there, who was a CIT trained officer. CIT is critical incident team, and it's basically people who've gotten this de-escalation training. What many of the CIT officers are women, and who are often excellent to deal with people in behavioral crisis in a way that is seen as less threatening. So she goes to a man's house, and it's in his apartment. It's in Englewood, which is a high crime community in Chicago, and it's a Saturday night. And he's sitting on his couch, and he needs to be calmed down and taken to a psychiatric facility. And she's doing a great job. She's really calming him down and building a rapport with him and doing everything you'd want to see someone do. But it's Saturday night in Englewood, and her boss is behind her. And while she's talking to this gentleman, her boss's cell phone is going nuts. He's getting all kinds of texts that say there's a shooting here, there's an incident here, we need you, what's going on? And at some point, her boss charges past her, jumps on this gentleman, and handcuffs him and manhandles him into the police car to take him to the psychiatric facility. And he says, it's not that anything bad was happening, but I just ran out of time. I had to wrap this thing up. And so the ability to have the resources to be gentle with people in behavioral crisis, it often requires that you just have enough manpower to do it, enough time to do it. And we found that often is lacking. And so, many of my progressive friends don't like to spend money on large police departments and putting more manpower into policing as opposed to other things. Many of the things we want police to do are very labor intensive, and particularly in those times and places where there's a lot of crimes per officer. And so that's something to be thought about. A second thing is what happens after officers do everything right. And one of the most frustrating things we found talking to officers was how often they would handle a behavioral crisis really well. They'd bring someone to a mental facility or an emergency department, and then 3 hours later they would see the same guy screaming at people in the street and feeling like nothing has been resolved. And then that makes the officers very jaded, and they start saying, well, if I arrest this guy and take him to the jail, at least I know something will happen. And so a lot of the problems that we associate with police in the system are really problems where the real key issues are further down the pipeline. And then finally, what's the prestige of these kinds of activities within the law enforcement ecosystem? One of the real challenges that some of the Chicagoans reported was just, it's not a very prestigious environment to be in the CIT type of teams. That, if you're in a culture that really rewards people who subdue that scary looking dude who tried to rob somebody, and you sort of tackle that guy and handcuff him, if that's what's going to get a lot of prestige, and the ability to talk someone down and avoid violence is considered to be kind of a touchy-feely thing that's not really respected, that's a real problem, in that organizational culture. And so the crisis response units often reported that they weren't particularly respected within the broader PD, and then that creates a real problem for them in getting people excited about learning these methods and following them. So now let me get on to the administrative data. So we have data that comes from the Chicago Fire Department and which CFD, and the Chicago Police Department, and which is routed through the Office of Emergency Communications, OEMC. And this is the part of the project that Andrea has really been leading the programming and analysis of in a brilliant way. So we start with looking at the CFD ambulance data and doing text search terms to try to find within the complaint and impression fields things that we think are indicative of a behavioral crisis or something related to it. So we look for words like patient complains of agitated, anxiety, depression, crying and tearful, hostile, irritable, and so on. And we look for the impressions among the EMTs of things like agitated and combative, behavioral, psychiatric, taser injury, and we also have illicit drug keywords as well. Now, we'll know if police are on the scene, although the data are actually more complex regarding whether there was an arrest from that encounter. But we'll know from the EMS impressions that the police were there. And there's many complexities linking all these data sets together. I'm not going to talk about them today. The one thing I will say is that 80% of the actual work is the ostensibly boring data cleaning and linking and matching. Is Luttrell Smith really the same person as Luttrell Smith? And how many different ways can somebody misspell the word homeless, and so on? So there's a tremendous amount of work under the hood in linking and working with these data and wrestling them to the ground. So just here's our obligatory PowerPoint flow diagram. You can see that there's an incoming 911 call. The 911 staff and dispatchers receive the call, and they process it. They may dispatch a CPD officer. There may be an arrest. in which case there's an arrest record, which is very nice because you have a fingerprint verify. You know it's the same guy who's been arrested before if he's linked together in the arrest records because there's a fingerprint there. But there may also be a case record with no arrest, or there may be the fire department may be dispatched, or both. And so there's a number of decision points and associated data collection opportunities and challenges that come with how somebody moves through this diagram. And we have, when we think about the data flow, we have about 31,000 behavioral health involved ambulance data events as we describe them, involving 23,257 unique individuals who have a unique ID that's assigned by the CFD records. In the arrest data, we have about 85,000 events corresponding to 62,000 unique individuals. We then do probabilistic matching to merge these things together and try to work with those, because we're very interested in behavioral health involved events where both an ambulance and police are involved, and what's going on there. And so what we find is there's 1,842 unique individuals who show up, who have a unique ID within the fire department data, and who have a unique police IR number. And that 1,842 people are kind of the first layer, what we might call, we call them at-risk individuals, where we see there's this police-ambulance interaction. And then within that, we further go down, when we try to look at high users, we further filter down to 330 people who have more chronic use that doesn't seem to self-resolve. So we have that group of 1,842. They've had at least one CFD behavioral health event during our 12 months of data, and they also have one or more arrests during that same period. And we call those people at risk. These are somewhat arbitrary definitions, but they're helpful for defining a population. So you can see in that Venn diagram, there's an awful lot of people arrested. There's an awful lot of people with CFD mental health events, and then the 1,842 in that Venn diagram intersection. Then we go down to this group at higher need of 330 people who you can see that they've had an event early in the year, basically, so we can see what happens to them later in the year, and then they've had at least 4 emergency events of any kind during that 12-month period, and also at least 1 emergency event in at least 4 distinct months within that 12 period. So these are people that are having a sustained problem. So we define this group of 330 people. And one thing we learned doing this is you can see a lot just by looking. And one of the most helpful things that we did as we tried to understand those 330 people is we just took each person and just printed out all the records we had about that person and went through it longitudinally. So here's an example of a person where I'm going to track through a little bit what's happening with them. So all the needles that are pointing up are their CPD arrest information, and the needles that are pointing down are their CFD mental health event encounters that they're having. Okay? So here's a person, they start out day 3, misdemeanor arrest for harassment. CTA is the elevated, is public transportation. So misdemeanor arrest on day 3. Then another misdemeanor arrest on day 31, retail theft at a grocery store of alcohol. One of the really common things that we see in our data is the number of people who are shoplifting alcohol at Walgreens, something like that, and they come into contact with security. Sort of survival crimes by homeless people with an alcohol problem. This is a very typical kind of an arrest. And then we see on day 63, we see CFD is called twice within hours. So this person's having a psychiatric episode involving alcohol, taken to an ER twice on the same day on day 63. Then we skip on ahead and we see that days 122 to 164, a person's arrested 5 times, including 1 felony, and has had 4 CFD events. They disappear for a while, by the way, after that. Maybe they're in the jail. We don't exactly know. Day 268, they're requesting a rehab and transported to an ER. this is a fairly representative, really high user trajectory for this person. And I would say someone like this, one of the things that really strikes me looking at these data is that nobody wears an entirely white hat or black hat. You see some guy where you see he's going to the fire station requesting addiction treatment and requesting help. And you say, wow, this person's like the poster child for Obamacare and the need for effective treatment services, and that's actually totally true. And then you say, well, there was the time that he was pushing women up on the train tracks, and then you're like, whoa, this guy's also kind of dangerous. And people with unmanaged serious mental health problems, particularly when they're dual diagnosis, they often, in this population of high users that are having police contacts, they have complicated stories that's hard to label them with some simple stereotype. Here's some of the top 10 folks. Here's the top 10 folks that we identified in our data. So you see, like individual number one, he's had 42 emergency events. He's had 37 behavioral health involved CFD events, with the ambulance folks, and he's also had 5 where he's had with police involvement. And he's been arrested 5 times. He's had 2 felony arrests. And one of the interesting things about these top 10 folks is that some of them would not have looked like they were really the super high users if you just had one data set available and not the other. If you look at person number 6, that person, if we just had police data, we wouldn't have particularly identified that person as a really high user. Actually, person 6 is arrested 13 times, but person 5, you look at some of these folks, and you really need to look at both the police and fire data to see, oh, wow, this person really is having a lot of complicated interactions that may or may not be resulting in arrest. So we also looked at top 10 places. And it was interesting when we talked to the fire folks. We first showed up to preview the PowerPoints I'm giving you now. We showed them to the EMTs, and we had a whole analysis that I did based on zip codes. And I started talking about maybe there's a neighborhood effect in this particular zip code. And at some point, I paused to take a breath, unlike today. And one of the EMTs said, "Dude, that's the end of the red line. There's nobody in that zip code. We're never getting calls for people who actually live in that zip code, and that's a guy who's asleep at the end of the red line." So we found a lot of action at transportation hubs. We found there was a homeless shelter where there were quite many calls. Places that we could actually intervene by having first responders talk to the staff of these places to figure out, hey, how can we manage these things better? And so looking at these top 10 places was valuable. We also looked at how these populations varied, and who were the individual human beings that we were finding. Mean age was early mid-30s. The folks that were involved a lot with ambulances, but not a lot of arrests, were a little younger. We found quite a few of the really high use people were homeless, and probably about a third of them were homeless. We did find that when we looked at how much of the data was accounted for by the high users in the high locations, that they didn't account for a huge percentage of all the calls that were made. I thought that the really high users would account for a higher percentage of the calls, and that the really high use locations would account for a higher percentage of the calls than they actually do. This data, it's not like Medicare health data where the top 5% of people are accounting for half the costs. Not quite as concentrated as that. Okay. So now we get to where predictive analytics comes in. So everything I've talked to you about so far is descriptive and to a great extent kind of retrospective. Here's a bunch of people that have made very heavy use of emergency response systems. If we brought machine learning into the picture to try to predict who's at high risk of having a call with a behavioral crisis, can we do better? So we tried to use the linked data sets that I was telling you about to identify a group of people who come into frequent contact and who could benefit from proactive services. Assertive community treatment being the most prominent one. So Andrea led the effort to build tools that tried to be predictive of this. So this is just every slide. Every presentation has to have a cool slide of a data pipeline. So this is ours, and as I mentioned before, when you write a paper, the last couple of these blobs would be 90% of the paper you write. But in the actual work, the first two blobs on the left are where the bringing the raw data into processing is where like all the real work is done. Even though the paper is all about which machine learning algorithm does the best and that sort of thing. So a huge amount of work under the hood that's been done to prepare our analysis data sets. So we use demographics and event histories to predict who is at risk for a behavioral health involved encounter that has police in it over the next 6 months. So we have a set of predictors. We feed them into a machine learning algorithm, and then try to have which feeds out predicted probabilities of a crisis event in the 6 months that follow a 12-month identification period. So we found, by the way, that random forest specification did quite well, but we're working on ensemble models and other approaches to do better, and we're happy to talk about that. So one question that we had when we implemented a random forest classifier, we tried to understand if we had for a given individual what their risk was. When a call comes in, how does a classifier compare? How does a random forest classifier compare with what dispatchers actually did on the same calls? And so we looked at what 911 dispatchers actually did in the way they defined these calls. And what we found was that the dispatchers were very, very good at detecting a call that might have a potential problem. We found very, very few calls of a mental health crisis that the 911 operator did not recognize. We did find that they potentially were being a little over-inclusive. So we found that our classifier had a much higher positive predictive value in that if a case was labeled as a potential behavioral health crisis, it was more likely to be one when it came through our classifier than when we compared what the 911 operator marked down with what the EMTs found when they showed up. So, which I think is probably a sign that the dispatchers are doing a good job. They're erring on the side of being careful when they assign calls. We also tried to compare, suppose we just had a rule that was someone who's a high user in the past, and every time there's a call that comes in with them, how would that compare with the classification rule? And again, what we found was that rule was a little bit more sensitive than our random forest classifier rule was, but it was also that had a much lower positive predictive value. So we generated more kind of false positives involving people who in the past had been high users, but this particular call might have just not been one that involved a behavioral crisis. So we have these classifiers, and so we can identify people that we think are at risk through machine learning and other methods. Can we engage and help them? And so we developed a pilot that was based on the premise, hey, why should we wait for the 911 call to help you if we think that we have a decision analytic tool that says Harold is at high risk of a behavioral health involved 911 call? Why don't we send someone out before that happens? And so we developed an intervention called the Mental Health Emergency Alternatives and Referral to Treatment Intervention that tried to use these methods to identify people and serve them in a proactive way. And I should say that this is a partnership among many people, the fire department, the police department, the mayor's office, and also a treatment provider called Thresholds that delivers assertive community treatment and related challenges. And so we've just done a pilot where we've tried to reach out and engage 20 identified individuals and see what happens. I should say because of IRB, we actually had to first send our own staff out and consent people because this was a research study. We requested to people, can we give your name to Thresholds? And we had these, and I'll get to that in a minute. But a very challenging pilot study for us to do as a research unit because ambulance data are HIPAA protected. And so we can't give ambulance data concerning any individual without their consent in the configuration that we had for these data and for the study. So ACT, I won't say a lot about, but it's an evidence-based comprehensive community treatment model. And the idea is you go to the person and you give a comprehensive and flexible set of services to that person. You help them stay on their medication. Maybe they have some survival needs that you help to meet. You have a very low staff to client ratio, 1 to 10. And it's quite costly and intensive, but for a person with serious mental illness, it is reimbursable through Medicaid. And so there's a viable financing model to support ACT for individuals with pertinent diagnoses. So over the past 8 weeks, we've been out and our University of Chicago outreach team has been finding and engaging people at immediate risk. Most of them have been identified because of their previous use patterns, but also we've used machine learning models as well. This pilot has been a sort of wild ride for us. We have an outreach worker. We have 2 outreach workers who work for the Urban Labs, Jessica Smith-Natassi and Liberta Livingston. When we first tried to hire outreach workers, my thought was, I want to hire LeBron James, because we're sending people out in the community to find someone who has had behavioral health involved 911 calls. It's a little scary from my point of view, in terms of staff safety. I couldn't really afford LeBron, so Jessica and Liberta, came on, did a fantastic job, and it's just been an amazing experience for all of the entire team has just done a fantastic job. We actually look through the records, all the arrest records, all the CFD and counter records for each person that we identify through our data analytics. And we look for people that seem findable. So someone who's been arrested where there's a specific address, that's a great place to start. And also someone who doesn't pose an obvious safety issue for our staff. So if people have had weapons charges in the past or recent sexual assault, I'm really not going to send these, Roberta's 68, and Jessica is, young enough to be one of my students, or recent alum. I'm not going to send them out to, if Ralph is under the bridge and he's had lots of weapons charges, I just don't feel comfortable in this pilot sending out for that. So very interesting to look through all the records, but we identified a set of people that we sought to engage. And so far, at last count, we've engaged 18 individuals who've consented to services so far, and people are pretty receptive to the services that are provided. Now, our ability to retain them in care is a little bit less certain. One of the challenges that we have is a lot of the people require intensive services, but they don't actually fit the model of ACT perfectly. For example, they could have alcohol disorders, but they don't have a serious mental illness. And so we have to be able to find other kinds of supports for them that are helpful, or they're homeless and what they really need are housing supports. And so we have a real challenge how to meet the array of their needs. We also have a problem that there are some very high priority people that we can't find, or that I just feel ambivalent about sending out my own outreach staff to engage them, given some of the safety issues. So one of the things that we need to work on looking ahead is other ways we can find those people, say when they show up in the emergency department. Can someone serve them in those moments? Can someone recognize, hey, this person is a particularly high priority person, and help them? There's definitely a group of people that we cannot find through street outreach for various reasons. So we have many practical questions that have come up in this pilot that we're working on now. So I'm going to stop here and take a breath, but I'm happy to answer any questions that folks may have if anyone is still on the line with me. So thanks very much for listening to my presentation.
Harold, it's Bruce. Thanks for a great presentation. It was really fascinating, and you led us through it wonderfully. You mentioned that the services that are being offered to these high risk individuals are quite expensive. Mm-hmm. Can you give us a sense of what that cost is and how that compares to the cost of responding to them through the healthcare system?
That's a great question, and I would say that there's two different aspects of that. One is the complexity of it is significant because you have to send out a whole street outreach team to engage people, figure out what their needs are, which are often quite varied. And then the follow-up is often there's conventional health care required or conventional psychiatric care required that you're trying to engage them in. I must say the street outreach workers are quite underpaid. So unfortunately, one of the ways that the model is made to work in practice is by hiring workers who are often getting paid like less than $30,000 a year to do some of this stuff. So I don't have for you at this moment the per person cost of ACT. I will send an email afterwards where I find this, but it is both in the cost and complexity. Our partners tell us it's a major challenge, and they're at capacity. And what they're doing with many of the people that we found in MHART is they're putting them in slightly lower intensity modalities that are just cheaper for them to provide, and particularly because Medicaid is so diagnostically based. That's a real problem. There's a bunch of people whose only real diagnosis is that they get drunk a lot, and when the police show up, they want to fight with them. And that's not, you can't get ACT reimbursement for those type of problems, but obviously that person needs something that's like ACT to try to help them.
So, do you know what the Medicaid reimbursement is? Is there a specific code or set of codes that they're using that is unique to Illinois, or is that not the case?
I think it is unique to Illinois, but I think almost all of the ACT efforts around the country are somehow pegged to a serious mental illness diagnosis. So there's a list, so you'd have to, there's a checklist that you basically have to, and there's a very high focus on bipolar, on various kinds of schizoid affective disorder thing, sort of the list that you would expect, and there's many people who just have other issues that just don't fall on that list.
Thanks.
I work in the ER here, and so the two things that I don't have a terribly well formulated question, but a couple of thoughts. You asked whether or not there is any action or similar type of activities in Philly or Pennsylvania. Yeah. There is actually some new initiatives that are rolling out literally this week, focused on embedding social workers in high-risk communities with the ambulance, with the Philadelphia Fire Rescue, focused specifically on opioids, with the plan to initiate warm handoff from the field. I don't know, it's an interesting question about how many, whether having social workers that are trained to take care of patients with substance use disorder would be, useful or be able to help with other types of behavioral or dual diagnosis, and whether or not that may have some collateral benefits. Because I don't know of any other type of work that's going on in related to EMS that's focused on this types of outreach outside of substance use only. And I guess the only other thing that so I think there's some interesting questions, and we're actually very interested in evaluating some of the economic questions related to that. In the ER, as I'm sure you have experienced or know in your work in the crime lab, one of the sort of anecdotal, but I don't know how well it's ever been documented, is that emergency department and hospital security staff tend to be very well trained in de-escalation, and it becomes often a challenge when the police are involved. We, in the emergency department, we find that they're better off often not around, and we can do a better job de-escalating without them. But once they get there present, sort of all bets are off. And I don't. So anyway, so that was just being able to sort of understand and sympathize with your stories. I hospital settings, but including mental health settings, at least in my experience, or in the emergency department, and they often can add challenges.
So two separate things that both two great comments. I do think the co-responder model is very promising, particularly, just in the overdose context. It's so important to engage that person into services. There's so many of the people, they're resuscitated through Narcan or whatever, and then they're sort of lost to effective follow-up and some motivational interviewing techniques and so on to help those people in those moments you could imagine could be quite valuable. I think one of the things that our work also suggests is anybody going back to try to find those people after, you have in the EMS record, Harold overdosed and we intervened and something happened. Is anybody following up to see, a month later or a week later, is this person still engaged in services? It may be that the social workers, in that moment, it's hard to engage that person. He's intoxicated, he's just had this whole traumatic event happen. Wouldn't it be great if you could talk to him a week later and use the EMS data as a jumping off point for outreach and engagement? I would love to see that. On the police de-escalation point, one of the things that we find with police is a lot depends on both the psychology of the moment and what box the police put you in when they're interacting with you. And so, if there's a guy who's my age and he's got razor stubble and he's screaming in the street, and maybe he's a vet, something like that, it's very easy for police officers to be pretty compassionate and de-escalating in that context. And a 22-year-old muscular African-American man behaving exactly the same way is going to get totally different treatment. And even if the reason why he's behaving the way he's behaving is due to a mental health crisis, he kind of fits in a different box. And the officers there's much more of a sense of, I can't allow this guy to talk to me that way, especially in front of other people. If some, 62-year-old guy is telling me to fuck off, and he's standing out in the street screaming incoherently, people watching are going to think, it's kind of nice that officer's just standing there taking that, waiting for that guy to calm down. They think something a little different if he's a 22-year-old tough-looking guy and he's telling me to fuck off, and I'm being a little bit less aggressive. And things like that actually make a big difference. And so police have to somehow, the socialization of police and the way that they have been trained, for very understandable reasons, to believe the way I keep myself safe and keep other people safe is to establish my dominance in situations of conflict. That's not a great recipe for dealing with a lot of the people in mental health crisis. And that is often the way the police approach some of these situations. So I don't know if that's what you've seen in the hospital, but that would not surprise me. So those are my reactions to Zach's comment.
Excellent. Yeah, thank you.
It's Janet Weiner at Penn. How are you?
Hi, Janet. Very well. Nice to talk.
That was a great presentation. I just typed in a question, but since you're not able to see it...
I'm sorry. Can someone see all the questions? Well, please tell me your question, and then if someone...
My question is, have you given any consideration to how these predictive models can be used to prevent someone from buying a gun?
Oh, that's a great question. And particularly in the context of suicide, that would be quite important. I think that in general, I favor a permit to purchase type of a way that people should get access to firearms. And it seems to me that this is the kind of data that should be available to local law enforcement when permit to purchase systems involve. If I want to buy a gun, I have to go to the police station and basically get a permit. And the police can bar me if I'm a prohibited possessor, but they can also bar me if there's specific things in my record that don't legally disqualify me, but where they feel there's a well-founded reason for me not to be able to get a gun. And so if you looked at, say, the Massachusetts model, I think that a lot of this data could be available to police. We'd have to deal with some of the HIPAA issues, but it seems to me that should be part of... I think you would need a permit to purchase system in order for this to actually be operational. But that's another reason why that would be very valuable.